Welcome to the Igniting Impact podcast, brought to you by Public Knowledge. I'm Stacey Moss, the host of the podcast and the president of our management consulting firm. Our firm's vision is to be a catalyst for change, leaving each person, project, client, colleague, and community better than when we started. The Igniting Impact podcast is an opportunity to share with you what our clients and partners do daily to impact our world. We want to highlight this essential work and the work that they do for their customers and stakeholders that is changing lives, despite the many daily challenges that they face. On today's episode, we have two guests with us, Brandon and Kate. Brandon is the Chief Strategy Officer for CRISP, the state-designated HIE for Maryland, a nonprofit organization that facilitates the electronic transfer of clinical information between disparate health information systems. Let's start today by getting to know you both. Tell us a bit about yourselves, what you do for work right now, how you got there, who you are outside of work, and what values you live by. Kate, would you like to start?
Sure. I'm Kate Horle. I am the Health and Medicaid Industry Director for Public Knowledge. I spend my time working with states who are looking to build wraparound services for technology implementations. That includes everything from writing requirements to helping them think about how their people and their services are going to change as they build new technology. I got there because I was in the market for a new opportunity, and RDP at Public Knowledge teach means that I think you'd really love working for this firm. So that's how I ended up here, and I'm very happy that I've just spent a year of my life in that experience.
What'd you do before PK?
Before PK, I was the Chief Operations Officer for a health information exchange called Creo, now Contexture, based in Colorado. It's one of two HIEs there, and I spent my time there working very closely with the state of Colorado, as well as doing a fair bit of policy work on the national level and working closely with other HIEs as they, at that point, and me, as part in that hall, move forward in the exchange of data and understanding the clinical impact that has on patients here in their communities. So I'm really driven by my impact on the broader world, particularly folks who don't have a voice in the policy landscape and who may or may not be heard in the clinical landscape. My entire career has been working with communities from a policy perspective who don't always get their perspective heard or their needs met because of their place in our society. So whether that's Medicaid patients, or it's individuals, lower income individuals in the education system, or it's folks who are in the affordable housing world, that has really been my focus my entire career. I am a Colorado girl, so my time is really, and my life is really driven by my opportunity to get outside and to see the mountains of Colorado and the plains of Colorado, to spend that time with my family, hiking and skiing and cooking and eating, and then skiing more because I did a lot of the cooking and the eating.
Always connected.
Always.
Wonderful, thanks. Brandon, you want to share with us a little bit about yourself?
Sure. Brandon Neiswender. Right now I am the Chief Strategy Officer at CRISP Shared Services. The Shared Services portion of an HIE is all the technology, infrastructure, and governance, and all of those types of things that go on to support that. And I am doing business development with very little margin pressure, so it's a wonderful job at the moment. Before Strategy Officer, I was a COO of CRISP. As we built out and we scaled across multiple states. We don't only serve Maryland, we also serve the District of Columbia, Virginia, West Virginia, Connecticut, Alaska, with infrastructure and governance. So in my previous lives, I was a geek. I probably still am a geek. But a technological database administrator, wrote lots of programs, wrote lots of integrations. Interoperability was something that I ended up being good at and was able to meet up with some industry leaders, David Horrocks being one of them. And he asked me to come and take those strengths and build out a scalable technology infrastructure company. Okay. So outside of my job, I love to be outside as well. I love to fish and I love to golf. And I just love spending time with my friends and family and enjoy this wonderful life, loving other people and just being kind. I think this world is full of mean things, and we should always just be wonderful and love each other and not get too uptight about it.
Love it. Okay. Well, let's have you both tell us a little bit about what we're here to talk about today. Tell us a little bit more about health information exchanges and health IT systems. And what do you think the audience needs to understand about them if they are new to it? Why is it important, and why do they need to know?
So the core thing that people need to understand about HIE is it's really about making sure that when your provider is spending time with you in that 20-minute window you have with them, that they have as much clinical background information about you so they can make smart clinical decisions about you going forward. What you don't want to do is spend 20 minutes telling them every single medication, every procedure, every doctor you've ever seen. You want them to have that information already available to them so you can say, I'm here because this knee that I had surgery on 6 months ago is not working now, and I need help with it. That's really, at its very core, that's the impact HIE has on the everyday lives of individuals. The HIT work behind that is much more complex, and it plays a really critical role in the larger healthcare technology system that underpins all of the healthcare work that happens in this country. Whether you're in a hospital, you're in a physician's office, you're getting treatment for a substance use disorder, you're in a state mental health institution, clinical healthcare technology underpins that entire system, and making it work in an integrated, smooth way is really important today to how we deliver care in the most effective and efficient way possible.
I would say, just to dive one layer lower, there's, when we think about the health information exchange, we think about 4 main categories of workflow. And Kate alluded to the first one, which is treatment. A patient and a provider are with each other, and there's information that needs to be, mutually discussed. Then there's care coordination workflow. The patient may not be in the facility, or a healthcare worker is trying to understand where there's an opportunity to help someone gain access to new types of services. I think then another one HIEs do is reporting the analytics, trying to understand, gleaning some of the insights out of these large pieces of information that are oftentimes jumbled up and not connected very well, and providing insight, whether that's to payers around quality metrics, whether that's other types of organizations that need to understand patient cohorts, et cetera.
Public health.
Yeah, then the last one that I was going to mention was public health directly. Like, I do believe health information exchange and the underpinnings that you mentioned are getting a little bit more ubiquitous. It's going to be a little bit more easy. I don't like the way I said that. Take 2. It's going to get easier to access this clinical data at a provider level, et cetera. But it's not opening up pathways to, how do I get a referral to a diabetes clinic? How do I access this care? So I think equity and access are the things that HIEs will do in the future, and they'll actually become more of a data utility model. And I know that that's something that our industry is trying to think about. Like, data is a utility, and it's an interesting way to think of it.
Data as a door opener.
Yes.
Right. And HIEs really, in the future, the goal, I think, of the industry would be to act the same way your energy provider acts. So that it's just, your healthcare data is just available in ways that you want it to be available. When you open up your house and you flip on the light switch, you expect the power to come on. When you go see a clinical provider, you expect them to understand your healthcare needs. You expect your state to understand their Medicaid population and what the critical issues are. That's the public health and the data analytics aspect of it. That's the role that HIEs can play going forward, where they can help inform state Medicaid agencies about places where there aren't public health clinics because of the analytics that they're doing. So they can see places where individuals don't have access to care because they're traveling 30 miles to see a provider, because that information, that social determinant of health, transportation, is in their clinical record. That's the work that's coming down the pike for HIEs.
So in places where people still are having a hard time accessing their own medical records, do Do you feel like we are still struggling, or do you feel like there's still progress being made, even though it's slow, or do you feel like we're still struggling to make progress?
I think it's all over the place.
Okay.
I do think it's in some places in more rural parts of the country. I don't know if EHR vendors have implemented patient portals in ways that can aggregate this data and make it available in an easy way for patients. But I know...
No.
But I do know.
But in cities, maybe, yeah.
Cities, or where you have some of the bigger EHR vendors that have integrated at least the clinical data that they have access to. I believe that is happening and more people are using it.
Yeah.
Where you don't have very good access is public health, immunization records.
Yeah.
Those types of things I think are still difficult. And I believe some of the info blocking rules and some of the new regulations that are coming out at a federal and a state level are going to make people think about new ways to start delivering this. And I don't know how many people want their immunization record on their watch, or I don't know what the total number of people, like I think we all assume everybody would come and get this information if we made it available. It's a small percentage of people, but the small percentage of people that want access to it need access to it to make their lives better.
How much is on our phones right now, and to be able to have access to those records on your phone, or the records for your children on your phone right now, I think it's such a huge opener.
So Stacey, I think you've actually hit one of the big pain points that we certainly saw in the HIE world when I was there a couple of years ago. And that is that people want access to their children's records.
Mm-hmm.
So every year you have to provide that information to the school system, you have to provide it to daycare, you have to provide it to camp, all those places you have to be able to provide clinical records to. And it's challenging for providers. Many clinics now have a person who does nothing but answer those requests from parents and deliver forms for physicians and sports and all those things, right? And it would be really nice to be able to say, oh, I've got to get my kid's updated immunization record and deliver it to school. I'm going to draw that down from my state public health agency. I'm going to add it to a file on my phone, and I'm going to send it to whoever that person is at my kid's school. Yeah, right now that's really a challenging work. It's the on-demand aspect of record keeping that is the tricky part from a technology perspective. There's also a purely business problem in this space. And Brandon actually touched on it just quickly there. You have these large EHR systems who can deliver that data to an individual if they were so inclined for whoever is using their EHR. But most states have somewhere north of 50 EHRs operating just in their state. If you are in this country where people move between states all the time, frequently within a single year and then back again, so think about folks who live in Michigan in the summers and the fall and live in Florida in the winters and the spring, right? They have physicians in both places, maybe on very different EHR systems whose only way to communicate is through an HIE structure to get data about that individual. Or they're porting a CCD or a thumb drive. That's not good. That doesn't provide good care. It's also just not good record management, right? Because now my patient records are like floating out there in the world for anybody to get.
I think we're locked into a way of thinking about how data should move based on the way some of this EHR technology has been implemented over the last 15 years in our country. And I believe it's time that we take a step back and go, how could we also fix that workflow? So the pandemic brought very interesting opportunities for Maryland and CRISP to kind of take a look at this. An immunization for COVID, we were able to tell colleges on admission who was able to do that through FERPA regulation and consent. You didn't have to go get it as a patient. It was just available to your school. So cut out all of the annoying parts to individuals like, oh, I need this because it's annoying. How about we just cut the annoyance and say, school systems, what do you need access to? Why don't you work on the exception basis versus I need to do all of this operational overhead to and so I think if we start thinking about the actual problems on why someone wants that information available to them. Like, I don't think you're going to read it every day. I don't think you're going to go, okay, it's the 15th time today I checked which immunizations my children had.
Yeah, exactly.
So, like, I think we have to think about it, like, what problems are we trying to solve with that information in terms of simplicity of life?
Like, I don't have to deliver my kids' entire clinical,
Just their immunizations.
In the HIE space, I think we get locked into ways of thinking about moving data.
Yeah.
And then we get away from that and solve problems for people. Then we're creating value, not just moving data around and hoping somebody finds value with it.
And that's the beauty of the world today, is that there's now enough capacity to move data around that we do have the ability to think about it that way.
That's right.
5 years ago, we were still trying to figure out how to pull records in from HIEs that were serving rural communities because they were 6 generations behind, right? Now, we've got past a lot of that, not all of it, certainly, but we're moving into a place where now we can worry about, wow, we have so much data. There's volumes of it. How to iterate it in a way that's meaningful for whoever actually has to have it when they actually have to have it. Because they don't always need it. They just need it when they need it.
And governance is now the tricky thing.
Right.
Data governance, data privacy, FERPA versus HIPAA versus... Those are the things that I think there needs to be alignment around data access and use.
Some states have a whole collection of additional conditions that have additional layers of privacy that other states don't worry about. I mean, great examples, right? New York has a number of conditions that require specific privacy permissions above and beyond substance use disorder that's protected by 42 CF 552. In Colorado, it's all fair game. And it's so you have to create structures that enable Colorado data to go to New York. And what does that look like too? So I agree. I think governance is really tricky, but also it doesn't have to be. There could be in the future, there could be today ways to create governance structures that are both meaningful for patient privacy and meaningful for patient access. And building those structures in place becomes the critical aspect going forward.
Yeah. Okay, I'm going to turn us to impact. So one of our core values at PK is impact, and we've created this whole podcast around it because we really believe that that's what's essential to our work and essential to what we're trying to do, right, in this world. So impact to us means that we approach every engagement with our energy focused on identifying the right goals, the right outcomes, and the right strategies, and that we each have a personal responsibility to make a positive impact on our projects and our world. I'm curious for the both of you, what does impact mean to you, both at work and personally, and what impact do you hope to have on this world?
I think sometimes that impact is hard to define.
Yeah.
Is it legacy? Is it individual interactions with people? I think I maybe started out with this. I didn't realize we were going to impact, but like the world is full of negative impact.
Yeah.
And I think my children or some of my friends could smile one time when they thought about me after I wasn't there. I feel like I would have made a very good impact on someone.
Yeah.
I think from a technological perspective or a work perspective, I think impact is very similar. Like, how am I helping a person do something that's good for another person? And that could be a healthcare worker, that could be a patient, that could be, and so I think if we think about just making life better a little bit at a time, that's probably the most impactful thing any one individual can do. And I think different individuals have bigger impacts. And I think other people might just be able to make one person small.
So impact to me is always about the butterfly effect.
Yeah.
Right? So if I raise 2 humans that are good humans and they do good things in the world, then that might be my impact, which feeds into their impact, which hopefully then has that butterfly effect of rippling out to others, right? So it might be the little thing, it might be the fact that my son goes off to college this fall and he helps another student who's really struggling in calculus. And that kid passes calculus and can stay in college and goes off to, discover the cure for cancer. That's a little tiny butterfly effect. And I think that is where the impact becomes really critical and different and important. I also think impact can be, when you said impact, Stacey, my brain went immediately to like asteroid.
Yeah. You want to blow it all up?
Also, because impact is that one huge thing that happens that creates a legacy effect for all of us to expand on and grow that and change. And, maybe I think about the funds that high tech brought to rural communities, right? Places like the Colorado communities where you had a provider who could not have ever dreamed about creating a system where they could communicate electronically with patients that were 50 miles away. And high tech brought them that opportunity. That was a huge impact in both urban and rural communities across the United States. And it changed the way healthcare is delivered fundamentally. It created an electronic record system so that that data could be printed and shared, and it was no longer a word of mouth structure. It created an opportunity for my folks in Lamar to see a specialist at Children's Hospital in Denver via telehealth. Those are big. It was a big blast of something that had tiny little impacts, right? Changed the life of a family who didn't have to take a day off work to drive 3 hours each direction so their kid with cancer could see a specialist, but instead have a conversation over telehealth or over the phone and have those records available. So impact is a funny thing. I mean, I think Brandon described it right. There's a lot of ways to look at it. And personally, for me, I really hope that the impact that I leave in the world is, I don't know about if it's so much me, but I do have that moment of I want people to go, oh man, she made great lasagna. All about the lasagna. I love first handling dinners at your house on Sunday nights with Sunday dinners, Kate. I knew it. The things. It's funny. It's not so much the professional and stuff, but it is that I want to raise good humans that go off and do good things in the world. And I want their memories of their life at home to be joyful, and that they pass those joyful things on to their children or their partners or their friends in ways that are neat.
I think society is, unfortunately, you see lots of depression, and we understand some of the pitfalls of social media and things like this. I think we're being programmed to feel like impact has to be like a big meteor coming out.
A big thing.
That can cause a lot of stress. It would almost make you, it's a negative impact because you're like, I'm not good enough. And then you just can't just enjoy the small things like petting your dog or we have to make sure that I don't think you can make a big impact unless you have some level of contentment with the small impacts that you can make. You're not going to get trusted with $1 billion if you can't handle $5, right? And I just feel like we have to be a little bit, softer on ourselves, easier on ourselves about impact, because then I think that it can grow. Then make the small one first and let that ripple become a wave.
Yeah, and I was definitely raised in a way that made me think that my job was to have a big impact. My high school, I went to a high school and I was voted most likely to be president of the United States. And I thought I was going to go to college and play D1 soccer and become a senator and totally change the universe and have those big, meaningful impacts. And that's not the path my life took. And there have been a lot of years, particularly in the last 5 as I'm entering this middle of life time. And you have to reflect back and say, have I impacted anyone? And am I doing anything that is making a difference? Do I do something every day that can make a small difference? Do I try to save it all up for a big thing? What's the right way to have impact in the world? And then you figure out that there's not really a right way. You just have to decide that you're going to do the thing that feels like the right thing to do and hope that the impact is valuable.
I heard recently, a while ago, maybe 6 months ago, that you're not really happy in life until you realize that it's filled with grief, loss, heartache, and constant work. And once you realize that and you come to terms with it and you realize that life is just about learning from that and growing from it, and then you find happiness. And I remember realizing oh my gosh, that is all life is. And I'm like, how do I make my children realize that? How do I help them, right? How do I help them to figure that out earlier in life than I figured that out? Because it took me a long time to figure that out.
We're constantly trying to avoid those.
Yeah, and to help our children avoid them. You can't. And so
life is.
How do you teach your children that earlier on? Because it took me a long time to figure that out.
Well, I think our kids learned that lesson the hard way of the pandemic. They might have known people who died, They saw the impact on their lives, on the lives of their people that were really close to them, teachers, family, and friends, and they learned that in a very visceral way. And you're going to figure out how to get along with your siblings in the house because you're going to be with them. You have lockdown for some long period of time. As families, we're going to learn what it really means to be together. The American family, who's always been all over the place, is now in a space where they have, people lost their jobs. Understanding what that pandemic really changed the dynamic for all of us. And I think it did bring a full blown out, broad, brutal terms. The world is now exposed.
But I think that's why we have unknown numbers of depression and mental health and so many issues right now. Okay, well, back to HIEs on that happy note. What kind of impact do you think HIEs have on the world right now? What do you think the impact is?
Not a lot. We've spent a lot of time connecting lots of practices and trying to make data a little bit more available. I think in a business sense, I think HIEs are doing more impact to facilitate transitions of care. Maybe that has some value for individual patient outcomes, but it also has impact on cost of care. And I think that that's where most of the value in the HIE industry still is. When you impact or value, it's in notification that something has happened and there's a next step that needs to be taken. It's not, let me take a look at all of this data and assess it myself, whether that's at a patient level or provider level. So I think a lot of that impact is there, and it's been gobbled up by venture capital. That value and impact has been acquired and is now big business, which oftentimes big business does not necessarily have the right motives.
Yep.
I'm not saying they're bad. I'm just saying they're different motives and impact potentially. So I think we can do more, but again, I think we need to change the way we think about what we're doing. Like, why am I making this data more usable? To what end? Like, what is the one little piece of information that someone needs that can have an impact on a patient's life, a provider's workflow, a payer's quality? Like, all those things, we're not there yet. I think it's little bits of impact.
How do we get there? If you were king for the day, what would you do differently?
I think that as a capitalist, and this is all very different than the way I think you solve this with governance and very standard implementations of healthcare system.
Yeah.
Like, I don't necessarily know what that means, and I don't think that outcomes are exactly better for people in like national healthcare landscape. But if I were going to try to solve it, I'd at least say, hey, we don't need to spend, billions of dollars on interoperability. Let's just everybody be using the same system. Like that. Then we can actually think about the things that matter.
It's funny because we've been saying that in the Medicaid world for years too, is this doesn't have to be so complicated. We all pay a claim. Why do you have to process the damn claim 100,000 different ways so that you have 100 different systems? Like, why? Just so that people can get rich.
Yeah, markets out there that people has and does create complexity, creates firewalls. And
if you create complexity, you inevitably create cost.
Yeah.
And governance is such an interest. Like, I think about governance from a policy perspective, because that's just a nexus, right? And one of the challenges in policy and that has really bled to governance and speaks a little bit, Stacey, to what you were just talking about, is we always govern and build policy to the bad actor, the least case scenario. Instead of building policies that have rule for that most unlikely scenario, we build a policy that governs that most likely, at least likely scenario, which means we end up in structures that are super narrow and really tight and don't have any room for innovation, creativity, or solving problems like complexity, because we've created really narrow governance structures. And that happens in public policy in all kinds of areas. But because healthcare is a federally regulated industry and it's regulated in a number of different ways at both the federal and the state levels, we have created incredibly narrow policies across a whole variety of ways that make governance really hard. And it creates both an opportunity and a challenge for technology to navigate. And it facilitates higher levels of complexity because of those incredibly narrow channels of policy. I'm thinking particularly around how we govern substance use disorder data, how we govern what HIPAA really means, and how it, as opposed to how it's actually implemented, right? Which are two very different things very frequently.
Same with FERPA.
Yeah.
Same.
So for
Exactly the same.
FERPA is the first example there, where what FERPA really means and then how it's actually interpreted. And it is all three of those are interpreted to the most narrow, most dangerous experience, as opposed to the actual broad-based use case. Yeah. That's really challenging. So I think our desire to protect the least, the last, and the lost sometimes overtakes common sense when it comes to really building systems that are meaningful. And also, as a capitalist, I would say that creates opportunity. Capitalism for that we can take advantage of those environments to create structures, technology structures that are needed and can be very expensive. But I do also think it limits our ability to really touch as broad-based a group of individuals as we might want to from a technology perspective. I do think there's one impact that HIEs have that you touched on that is related to governance. And I'm thinking about, again, kind of a narrow use case, but a potential future opportunity. So as CMS is beginning to loosen some of the regulations that they've worked, so 42 CFR Part 2, which governs data use, substance use disorder data, as much change as CMS can do without congressional approval, super helpful. They also just recently released or changed the requirements for payment to specialists who are working with a primary care provider. It used to be that CMS wouldn't allow Medicaid to pay a specialist who didn't see a patient face-to-face. So if I'm a primary care provider, and again, I'll use a rural Colorado community, and I have a kiddo in front of me who I think might have a spiral fracture in her hip based on this x-ray I've just taken, but I'm not sure, I can't just shoot that x-ray to an ortho friend over in Guadalajara, for instance, and say, hey, can you take a peek at this and let me know if you think that's a spiral fracture or not? Because CMS used to not be willing to pay that because they didn't see the kid. Well, getting the kid, requires time and money, and like a lot of time. It can be months before they can be seen, right? So now we've got a person who's going to end up in an emergency room instead, because that's what I'm going to do as their PCP. I'm going to say, I'm not sure what this is. You need to go to the emergency room.
And the ER doc isn't going to know either.
And it's going to be a very expensive visit, right?
Yeah.
That $103 visit just became a $1,200 visit because they're going to go to the hospital. Well, now CMS is saying, we take it back. You, primary care provider, can call the specialist, and the specialist can bill your state Medicaid agency for that relationship. That kind of work. So now, HIE, because we already built the infrastructure, it's already available, the specialist can just go into the kid's record and look at the image and be like, oh yeah, sure enough, that's a spiral fracture. So they need to go see an orthopedic surgeon, and maybe they do need to go to the emergency room. But at least it's a planned adventure, right? It's now not just an emergent adventure. Those are the kinds of opportunities that exist in this nexus of the groundwork that HIE has laid and the role that our regulatory bodies can play when it comes to governance and policy work.
Kate, let me add on to that for 1 second. And I think where HIE does make a big impact is in states that have solved governance and have a large portion of their healthcare communities accessing it in the same way.
Where all the data's in there.
There are some states that have lots of data.
Yeah.
And they have this HIE, but many providers or payers or patients don't take advantage of it. So it's just there. In your scenario, telehealth or image exchange, Maryland is a very good example of most providers, many people using. We have 70,000 users. It's very, there's different governance reasons why there's so much of that.
But it's very ubiquitous.
Very ubiquitous. Like when Medicaid or the Department of Health needs to do something for its providers, they go to their HIE and say, push this out because I know it's already in the workflow, versus I have to go to 70,000 people, register them, train them, etc. And the image use case in Maryland, we're dealing with stroke patients. that are not at a hospital that can handle them, we can read that image in real time with someone else and determine whether or not that patient needs to be transported. So providers are using, there is impact on individuals when the asset at state level is being utilized.
Yeah.
For the clinic. And it's not every single time somebody's having a stroke, right? You don't always need to exchange all this information if you're going in and getting, you have a cold or something. But it's like,
I need it today.
I need it now.
Right this minute. And you can't have that kind of use if you don't have the infrastructure.
That's right.
So in states, I suspect that's where you're going, in states where you have a beautiful HIE that nobody uses, that infrastructure isn't in place, and you don't get the kind of care that you need, then you have a lot more cost, right? Things are much more expensive in that scenario because I can't look at the image, so I have to send the kid to the emergency room. And I could, they'd put a bit of hair in my x-ray machine. I don't know, right? So those are the scenarios where the lack of infrastructure has a significant impact on cost. And given that the cost of healthcare in this country is already rise at exponential rates in ways it doesn't rise across the rest of the globe, you would think that we would be smarter about that.
So in a state like Maryland that already has a large usage, and you talked about the impact to the individuals, what are some of the significant impacts to providers or to the state?
I think we have lots and lots of fun use cases. I will say this. Providers are bombarded with massive amounts of data, clinical decision support. It's a little bit overwhelming to, one, have to enter all that information as a provider. Yeah. Two, then you have to read it and understand it.
Do something with it.
An outcome. So I think in states like Maryland, because providers know they're going to one place or all of that information is uniquely integrated into their workflow that means something to them, it's great. For example, PDMP systems are often separate.
Prescription drug monitoring program systems. That's what people think.
In Maryland, one of the big keys was Maryland's Behavioral Health Administration decided to let's leverage the HIE and make sure that from a licensing perspective, prescribers and dispensers of Schedule 2 to 5 drugs would go to the HIE to access this information. Now, you have to have infrastructure to onboard all of these users and manage the licensure requirements, etc. But now they're there for PDMP.
Yeah.
You might be able to put an image next to them, make that easier. You might be able to put some claims data that says, hey, I might not have known much about this new patient that's in my FQHC, but because previous claims history, I can see what drugs they're on or what their diagnosis codes are. You can start pulling that together, and you almost create data by merging it.
Yeah.
And so I think that there's a lot of value there. And I think also
it tells a full story about the individual.
Yeah, and I think this is where health information exchanges, HIEs, are becoming really valuable. It's not just in the federally qualified health center way, the FQHC way, but when you think about that individual that might have been seen in an FQHC, it's seen at a hospital, and then ends up in a county jail or a state correctional facility, and the state correctional facility now has access to their clinical records from all those places and can make sure that if they're on medications that are helping them maintain a stable mental health condition, that they continue those medications, right? So that you don't have someone that's decompensating their first 30 days in a prison structure, which is not good for anybody, whether it's a county jail or it's a state prison facility or correctional agency. That's an expensive adventure for the state, for the individual, all those things, right? So we are down to those, what we used to think of as that would be nice to have. We're down to those, how do we make sure that those nice to have cases are happening in the healthcare world, except for where they're not.
Right. And I think the last mile that I see in the HIE journey is, big EHR vendors, TEFCA, those types of things, that big clinical data component, moving between those, it's going to get easier.
Yeah.
You have Commonwealth and eHealth Exchange and all some of these things that are moving. Hey, if I need to just know Brandon's records, I can probably query it. And if there's records out there, I'll probably find them. Where you don't have this is public health. You don't have this all PDMP type, all of those types of things where we have all these public health registries. In some of the states that we support, we're doing truancy and like absenteeism in schools, and could that be an identifier? And if you opt into these programs, providers might know that Brandon's child hasn't been in school for 3 days.
Yeah.
Is that, and those are really unique types of things where we're saying, oh, your HIE is now the lead registry, who's been exposed. Like, there's a lot of different ways where this small amount of data that's very, very valuable gets locked up in a system technologically and also from a data governance perspective. And I think some of that's like the last mile, like we should really be trying to solve public health issues.
Well, and those systems often aren't very sophisticated either. So technologically, that's the other hurdle too, not just governance, is my experience. So I think the impact for states, the public health piece, I think is where social determinants of health comes in, right? Like that's the final frontier, right? Like the major opportunity is how do we get ahead of this and how do we figure out how to solve for poverty and get ahead of so many of these issues.
Well, I'm gonna jump in on this one real quick because I have a little bit of an issue.
Okay.
It feels very wrong to me the way SDOH data is being managed from a business perspective. Like that feels like we're crossing a line of, we should not be trying to make tons and tons of money off of this.
It's monetized poverty.
I know, it feels bad.
Terrible.
And I think one of the things we have to think about is it's fine if you sell tools that do these types of things, but that data needs to be available and not locked up.
I don't think you can. I think it's a public health tool. I don't think it's a business tool. How do you make money off it?
I mean, this is the big challenge at the Mutual for HIEs especially because, I mean, a perfect example are food banks, right? Like, some of the most valuable and critical data that providers and clinical institutions want is access to food for families, because that is a huge piece of a broader healthcare. Nutrition is a core piece of a broader health system, right? And food banks, this is how it works. I don't know if you've ever been a volunteer at food bank, this is how it works, right? Somebody comes in, their name is Jane M. Yep. Phone number is 720-69 blah, blah, blah. Yep. Right? You go to a shelf, you pull Jane's box out, U4 bag, or however much she's registered for, you hand it to Jane, and Jane goes full. That is the technology exchange.
And sometimes it's written down on a piece of paper.
Right. I mean, they picked up the phone. Yeah. You checked their name off the list, Jane M. box on Wednesdays. Yep. That's it. That's the deal. And so, and some of that is a privacy issue, right? Jane M. doesn't need or want Elle to know. But Jane M.'s kid's primary care provider, pediatrician, does want to know. And Jane M. is probably okay with her kid's pediatrician knowing that, they have some food instability in their world right now. Yeah. And that data, free and reduced lunch data, access to transportation data, some of that information is actually available in some EHRs. But getting it out of there in a structured way where it can be useful is either heavily monetized and very, very expensive, or the people who can use it can't afford to buy it, or in the case of the food bank, they don't have a way to communicate it, right? So if you're going to make that data useful in a really broad-based way, the way we have with clinical information, states or cities or other public institutions are going to have to fund a system that is paid for by somebody else to enable homeless communities, secure determinants of health, other folks who are providing services to those individuals to be able to deliver that data. Because the food bank isn't making money on Jane. Their money and their stuff.
Well, and they're not making money off of tracking that data.
Right. Nor do they care.
Yeah.
Well, this is where I do think HIE is making an impact, and the way our community of HIEs are probably thinking about this.
Yeah.
There are vendors out there that you can go buy some of these tools, assessment tools, referral tools, etc. And those networks then become closed and only accessible by the folks that are buying that. And there's an interoperability issue. At Crisp Shared Services, we built an integration point If you create an assessment in an EHR, we can understand that assessment and make it utilized in another system.
Yeah.
If a referral happens in one system, we get correspondence. Somebody can know that Jane got her food because you open this up to the CBO community. This is where there is a large impact, and it's really just interoperability. This is like geek stuff, interoperability. Let the markets produce what the markets need to produce, and that's wonderful. I'm glad people are investing in these types of tools, but not everyone is going to use them.
Yeah.
So they need very robust interoperable platform so that if somebody creates an assessment in one place, another system can read it. And we have been making some strides in the District of Columbia specifically with the marketplace vendors that are doing this, and they are interoperable. So I think this can happen. And also then you have we call it tools of last resort, right? Let's say someone at the food bank wants to make a referral for Jane. You could. And you don't have to go buy tons of tech and subscribe to something. You can use a statewide asset that's free.
Yeah.
And it's not the most sophisticated thing in the world, but it does its job. Yes.
It does not have to be.
So it's tip for a food bank worker that she uses every Wednesday for a year and really trusts. I've got to figure out how to get we're moving and I don't have access to a bus line anymore. I got to figure out how to get my kid to school or whatever. That referral becomes life-changing for that kid and that family. So again, butterfly effect. It goes off to change the world, right?
Yeah.
These are the little things that really long-term have a huge impact on communities if we can figure out how to make it work and fund them. And fund them kind of in a permeable way. I think part of our challenge in the healthcare, in the HIE world, but certainly a part of the challenge in the social determinant, the communities that serve what we now think of as the social determinants of health population, funding it happens in 2 to 4 year cycles. That is not enough time to build a 128 unit complex for transitional housing for families and keep it going, right? That doesn't work. So how we figure out to create structures where there's a constancy in that funding cycle, and you can do that with accountability, you can do that with lots of other things, but it can't be a constant policy win. And that's where we are today.
It has to be sustainable.
Yeah.
Okay, well, let's switch gears a little. Each quarter, our podcast has a different theme, and this quarter's theme is reliability. So reliability is defined as the probability that a product or system will perform its intended function adequately for a specified period or will operate in a defined environment without failure. So when you think of health information exchange or health IT and reliability, what emotions or thoughts come up for you? What's your initial reaction?
I feel like reliability is table stakes. If technology doesn't work, you're not going to use it.
You only get one shot.
You only get one shot.
Literally, right? If you go in and it doesn't work, how often do you go back to that thing? And I'm talking about just generally, universe. You go to a website and you can't get it to open. Do you ever go back there again? Maybe one time.
Yeah.
And that's it.
I mean, we both built scalable HIEs, and I will say reliability is one thing that if you get it working, it can break and become unreliable again. And you have to really implement good process, good technology. You need reliable people to run.
Great communication you talk about.
Yes, it's anyway. I just think it's table stakes, and it's hard to unpack.
Yeah,
because the impact of reliability, you can't have an impact if you're not reliable, well, at the personal level and at the technological level.
And I think reliability means a lot of different things here. It does mean that when I read my EHR and it's the middle of the night and I've got an emergent kid in front of me and I'm pulling up CRISP or I'm pulling up Contexture, I want to know that data is going to be available to me so I can use it to help this emergent situation I have in front of me if I'm in an ER, emergency department. But it also means that if I do pull it up and it's not there, that's such a rare condition that I know that something is I think there's something wrong on my end, not something wrong on the HIE end, right? Like I immediately go to my DHR is down, not my HIE is down, because that doesn't happen.
Mm-hmm.
Those are the things that you really want to be, you want to be, but you also, for me, reliability also means that it's connected to consistency, right? So I'm using this information in a way that is all the time thoughtful for what it was intended in a really kind of process-driven way, so that it creates availability and reliability with my peers too. So my peers are like, oh, Kate always uses the HRE. She sees patients. I should do that too. So that we're all being consistent in our clinical treatment processes.
It's hard to build reliability.
Yeah, and especially in the IT or technology world, because you think of tech goes down, right? Like just in general, that's what you think of.
Because I have no laptop, right?
Yes. Yeah. Her screen went dark. Like
in a personal.
Yeah, like your phone breaks.
On Kate. I've relied on Kate for 25 years, but then the 25th year, Kate does something that is unreliable. Kate will be unreliable for the next 20 years until you can lose it.
It's so hard to build.
It's so hard to build and it's so easy to lose.
And you think of very large IT systems and how complex they are and how easy it is for something to go wrong. And again, I'm coming at this from large Medicaid system background, not large HIE, but I think of how often things can go wrong in large Medicaid system world.
Well, this gets back,
and they're not
to the level of complexity that we rely on all in our technology.
Yeah.
More complexity equals less reliability as a general, not 100% of the time, but very frequently.
Yeah.
The more things you have to break, the more opportunities there are for them to break.
No one will ever reward you for being reliable, but they will
punish you for being unreliable.
Yeah.
It's so crazy. It is true. And it's funny because, I have a son who has a very serious medical condition. And I have not thought about it until this moment that I use on my phone his EHR day in and day out for the last 8 years to communicate with his doctor and his care team. And I have all of his medical records in it and everything's in there and I use it all the time. It's very reliable, but I've never thought about it until this day that like everything's in there and all of his prescriptions and I can, access everything, all of his medical results and communicate with everyone. But I've never thought about, it's never gone down. It never breaks. I never have an issue logging in.
And if it did,
I'd be angry.
You'd be very angry.
But I've never once been like, hey, thanks so much for being so reliable. Yeah.
I mean, that's true. Again, back to the utility model or your energy provider or your water provider. When you turn on your faucet,
you expect water.
And guess what? If you live in Jackson, Mississippi right now, that's a dicey proposition, right?
Yeah.
You might get water, but you don't want to drink it.
Yeah.
And it's so disconcerting when the things that we expect to be there, our clinical records that we're using up for clinical decision making, our water, our power are not there.
Yeah.
That it makes you distrust the system.
Yeah. So one of the things that we think about I think about with impact is like the collective of impact. Like every little impact eventually drives us towards more progress, right? And so as we have, each impact builds upon the one before it and we learn from it, right? Whether it's the impact is good or bad, right? And sometimes we learn more from our failures than we do from our successes. And those lessons learned help us to do something different the next day or do it the same. And so I'm curious what lessons learned you each have that you could share with the audience that you kind of take forward into the next project or the next day that ultimately you think move the needle and will help us make more progress in the world of HIEs or in the world of HIT that you think will just help us do things differently in the future and make us help us make a bigger impact and more progress.
The biggest lesson learned I have from all of my years in HIE is that I don't feel like we make impact at a population level. I think we make impact at a personal level. The big population stuff, we're not moving the needle on that, but every once in a while there is an individual that has an outcome that was better.
So you want to drive towards that population impact faster than we're
Yes, I don't think that HIE's job to figure out, how do we get people to stop smoking or to drink less, or people have to be compelled intrinsically or extrinsically to make those types of decisions, make the tools available, and then so that people can think about it and determine how do we collectively get there. Individually, I think we're making impact, and that's a good lesson learned, but I think everybody wants to answer a bigger question.
Kate?
That's a tough one.
So I'm a big believer that fail really means first attempt at learning.
It does.
Right? Yeah. Studies show that humans learn far more from their failures than they do from their successes. We tend to walk away with successes. We carry our failures with us as lessons learned. And gosh knows why I have plenty of failures and lessons learned.
Yeah, you and me both.
But I think in this case, I keep coming back to the reliability conversation too, and how those two things, the lessons learned and reliability, are really integrated and connected with each other as it relates to this work. I feel like HIE had a minute there where it was so busy trying to change the world that we sacrificed reliability of the process. And this was a few years ago when it was very scattershot. Every HIE was doing different stuff. Nobody was being consistent about it. Data delivery was messy and ugly and really challenging. A lot of that has changed now, and there were a lot of lessons learned about what people want and what people need. But I also feel like in this country in particular today, we have such a mistrust of other humans and their ability to be our partners in success. So that means we don't trust our governments, right? And then people don't trust government. They often distrust big, large institutions or organizations to be their friends. And I don't know about you, Brandon, but the number of times I answer the question about which government ran my organization, it was a daily, but here, it made it like, and trying to be able to say to folks, no, I'm a community-based HD. We're an independent, not-for-profit organization that does a lot of work with governments and municipalities, but is not run by a government or municipality. And also at the same time say, it doesn't matter if I'm run by a government or a municipality or not, because what I'm doing is something that will make your life better. I'm going to help you be clinically in better condition than you were before, because your provider can make better clinical decisions about you and in partnership with you as part of your care team. I feel like there's a lesson to be learned about not being afraid to say, just because we're pulling in data from 70,000 providers, we have literally 10 billion bits of data in our system, doesn't mean that I'm going to take over your life and make it miserable, right? Organizations that do big work in partnership with government, in partnership with other big clinical institutions, have good intentions. And I don't mean the kind that pave the road to hell. I mean the actual kind that have real impact on people's lives. Our ability to trust in this current environment is so badly eroded that I worry HIEs will struggle to cross that very last mile, which is a real long mile, by the way, because there's so little trust in big institutions to provide that kind of information, whether it's care, whether it's housing, whether it's, what kind of information schools are delivering to students, all of those places. We are so distrustful now. It really is disheartening for me to see that. And to raise kids in an environment where I want to be able to say, it's okay to trust your school system. It's okay to trust your big academic institution. They aren't necessarily out to fleece you. It's okay to approach with good and, assuming a certain error, if nothing else, approach assuming neutral intent, right? You don't know that they're in there to get you. It might all be okay.
It's part of what we lost, I think, in the last 3 years, is the ability to assume positive intent of others. It's part of what we lost.
And it reduces the ability to have impact.
Yeah.
Because if you don't have people that will trust you, you can't impact their lives. So how do we rebuild that?
Yeah.
That's a bigger social question that we haven't been able to tackle.
Yeah. Well, we built this podcast around one of our 3 core values, impact. But to close out to the podcast, I'm going to ask each of you to share your wisdom on our other 2 core values with our audience. So, and our other 2 core values are inclusion and teamwork. So, and I'm going to ask you just 2 questions on them. So I'm going to read you our definition of each of them, and then I'm going to give you a minute to think about it, and I'm going to ask you to give the audience your best advice on achieving them in the workplace. There's no wrong answers. It's just fun, and a good way to kind of share some advice from brilliant people. Make sense? So I'll read you the definition. I'm going to ask you the question is, with that definition in mind, what's your best advice for achieving a high level of that in the workplace? You'll give me your best advice, and then we'll move on to the other one. All right, here we go. Okay, inclusion. Our definition is we recognize the fundamental value and strength of all individuals. Our teams create a safe space for open, inclusive, and diverse participation of all peers, clients, and ideas. We build high levels of trust and belonging. So with that definition in mind, what is your best advice for achieving high levels of inclusion in the workplace? Start.
Not being a butthole.
I love it.
Yeah.
Yes. It really is not that hard. Not rocket science.
To respect an individual for being alive. Like that.
You're a person.
Yeah. There's tons of value in being alive.
Yeah.
Like, I mean, yes, everybody has opinions, and if we're all very divisive, but like, just I don't know how to say. It's just okay to just love people and include them and not assume that they're out to get you.
Yeah.
Just be nice. Like, how's it been? What do we say to your child when they go to kindergarten or first grade, right? Be nice. We say that. Be kind to dog. Be nice. It's not actually hard.
Love it.
We can all do it. We've been learning how to do it since preschool. Literally.
It's with varying degrees of success.
Be nice. Yeah. Then everything else is a lot easier, honestly.
I do feel like in the workplace, though, like sometimes I have a little bit of a reputation of being a little louder and enforcing an opinion, like being like, we're running large companies, right? It is tough.
Yeah.
I think you can be nice, but be firm
and passionate.
Yeah. All of those things. Like, it's not always about, just always calm and always affirming. It's like, hey, we need to get this done. And you might not enjoy my passion about why we need to do it.
Yeah.
But that's not being nice. That's like, collectively, we're a team.
Yeah.
But we're going to have to work together. Now, you can not be nice, and that's just going to ruin productivity. Like, nice is like respect as well, right? Like,
for sure.
Like, not like that. That's the thing. Like,
and I'm old enough to remember when women were tremendously disrespected in the workplace, right? Especially, God forbid, if you had any opinion about anything that might be somewhere outside of like 1930s kitchen baking shoe, right? And I want to be really clear that my grandmother was a divorced single mom librarian in the 30s or early 1940s. So I have a huge amount of respect for that. But that said, I do think, like, don't be an asshole. This is important. I also feel like, so there's a great book called 10% Happier. Guys, the author's name is Dan Harris. And it's about his journey to meditation. My husband gave it to me because he's like, you're this guy. But
you need to meditate.
but my point is that he goes to this phase where he was like, I'm so zen that I'm losing my edge, right? And there is a way to like not lose your edge, to be clear, to be firm, to be kind, and be respectful and be all those things and make a change in the world without being run over or walked on or any of those things, right? You can be nice and not be driven on.
Yeah.
And we all should be there.
Awesome.
That's how it should be.
All right. Okay. Teamwork. Our definition for teamwork is we do more than just work together. We respect, trust, and care for each other. This collaboration and belonging extends to our clients as much as our colleagues. So with that definition in mind, what is your best advice for achieving high levels of teamwork in the workplace?
I think it's part of being a team is having a clear objective. Like if you're going to function as a machine, that machine does something.
Got to know where you're going. Yeah.
So I think I've never really seen a team that was doing a good job that had a bad leader.
Yeah.
You know what I mean? That couldn't communicate why or what they were supposed to do, whether that's a sports team, whether that's a technology team, whether that's whatever. So I think for me, the most important thing about teamwork, and Kate and I have both been in maybe that leader role. I think leaders have a lot of responsibility to show where to go or what to do. Maybe not as much about how to do it. That's why you have the team.
Yeah.
So that would be my 2 cents.
Share the path and vision.
Yep.
I would say that teamwork, really successful teams have a couple of things in common. They have a capacity and a willingness to communicate openly and honestly and frequently. They have a capacity to compromise, and I mean that in the best possible way. So sometimes the path you choose to reach your objective is not the path that works. Like I might make a leadership decision that says we're going to go down road A, and we get through the third block, road A, and then find out that not the best choice, right? As a leader, I have to be able to hear from my team, hey, we're going to have to go around the block and go down road C, and be okay with that, and recognize that that is part of what a functioning team does, is really can pivot and go. And it's not about me. It's not a personal thing. It's about achieving their outcomes. So those 2 things are really important. And I think the third thing that's really important, and this is easier said than done, is that you need to have a team that's a whole brain. So teams that all think the same, communicate the same, work the same, don't discover that road A doesn't work, right? They're not innovative because they all think the same. It creates conflict in your teams when you have a lot of people that think differently, that process the world differently, when you have folks who are processors and people who are action-oriented. You have people who are structurally minded and people who are conceptual. It creates conflict in the teams because folks need time to process and some folks want immediate action, all those things, right? A strong leader puts together a team that is very, very different in its thinking and can help everybody feel successful in that process. And I've had leaders who didn't like that. They didn't want teams that were all really different because they couldn't manage that conflict. I've been on teams like that.
They're probably inefficient.
What happens is somebody gets cut out of the decision-making and gets resentful, right? Whoever doesn't align with the leadership vision or the leadership process gets cut out of decision-making and then gets resentful. And if we're talking about a senior leadership team, that division then starts to struggle, right? Because they're not connected to the organizational vision. They're not connected to the leader vision. And so ensuring that I think a whole team is really critical because otherwise you don't get good innovation, you don't get good creative thinking. But you also have to enable all those people to do their thing and feel good about it. Those are all critical pieces of really successful teams.
All right. Okay. Well, I can't thank you enough, both of you, for your time today. And what a privilege it's been to be here with you both, to connect, to learn, to grow, and to share. Until next time, this is Stacey signing off.